start talking about some of the complications related to fractures. And there's several complications. We've already talked about one, which was avascular necrosis, and that's when the blood flow is disrupted because of a complete fracture. Happens frequently in people who have hip fractures and or complete fractures. Patients can also develop a fat embolism, and that most frequently occurs in the elderly and people who have hip or pelvic fractures. And a fat embolism is just like any other kind of embolism. If it travels throughout the body, it can cause problems. Now, it usually occurs with long bone fractures, and the fat globules travel and can cause acute respiratory issues and problems with organ perfusion. DVTs, of course, is another possible complication, and that's something that you deal with any patient in the hospital is the potential for developing DVTs. Osteomyelitis, which is a bone infection, and we're going to talk about that. And then also, let's start talking about compartment syndrome. In general, you'll see that there's three types. There's acute, there's a chronic, and then there's a crush. When we talk about compartment syndrome within the realm of musculoskeletal disorders and in the setting of a fracture, that's because you have, and there's groups of muscles that are sheathed by a membrane, a fascia, that is not very flexible. It doesn't allow for expansion very well. Will act like a capsule, like you have on a liver or something, or your kidney. So the basic problem with an acute compartment syndrome that we see with fractures is that the blood collects in these muscle compartments, and it causes compression of the blood vessels and nerves, and it causes extreme horrible pain that's not alleviated with pain meds or by elevation. And when one of the hallmark signs of it is passive movement, if I were to lift somebody's extremity and they were suffering from compartment syndrome, it would cause an excruciating pain. It is that's one of the hallmark signs of it. Risk factors include trauma, surgery, or crushing injuries. So we talked about the idea that you can have compartment syndrome from blood collecting in the muscle compartments that are surrounded by the fascia, but you can also have compartment syndrome if somebody puts a cast on, if somebody's casted, and either the edema is still developing or it redevelops. So you can also have a problem with casting. Now, compartment syndrome is more likely to occur in people who have bleeding tendencies, such as people who are on anticoagulants or who have some kind of hemophilia. So people are taking aspirin, taking NSAIDs, something like that. They're at increased risk for bleeding and increased risk for development of compartment syndrome. Okay, we're going to look at the 5 Ps again. Remember, we talked about the 5 Ps earlier on when we talked about a fracture and casting somebody and monitoring neurovascular. So the 5 Ps for this include pulselessness. Now pulselessness is a late sign. Okay, it's not one of the early signs. You can have decreased pulses. Pulselessness is a very late sign. Let's see, pain, paresthesias, and numbness. So far we have pulse changes or pulselessness, pain, paresthesias, paralysis, pallor, and if you can palpate the muscle, it's not casted yet or they're in traction or something like that, and you palpate the muscle, it's going to be hard and swollen from the edema, that blood that's trapped in that fascial capsule. So they'll have the 5 Ps. The pain is unrelieved by elevation or medication. I talked about the intense pain with passive movements. The muscles are hard and swollen. And I talked about the pulselessness is a late sign. Don't forget the pallor, though. They'll have some paleness, and they'll also have the paresthesias. Now, treatment for compartment syndrome is a fasciotomy, where the doctor goes in and opens up the muscle cavity, the fascia, slice the fascia open so that the blood can escape. A lot of times this can be left open. Look how deep that is. Because it had to get deep into the muscle. Other ways to treat it is to bivalve a cast, and that's where the cast is cut down on each side, removing the constricting bandage, and they can do pressure monitoring by inserting a needle as a transducer and monitoring the pressure. And I've seen that done up on the ICUs before. Nursing interventions, nursing considerations prevent further complications, so you need to continue to monitor neurovascular checks, treat the pain, and also dressing and wound management. Like I said, these wounds, if they have to do a fasciotomy, they're frequently left open until all the edema goes down, and they're pretty certain that it's not going to return before they close that. Okay, and don't forget that there's still the underlying injury that has to be taken care of. All right, so osteomyelitis is an infection of the bone, and this can be acute or chronic. But you can look at this guy's foot here and tell that he's got an infection there. But I want you to look at a couple other things too when you look at this guy's foot, is look at his toenails. I'm just saying that this guy here, I don't know if he had a cast on or what was going on that he developed this osteomyelitis, but you can look at his toenails and see that they're not well groomed, and maybe, he's got an issue with self-care. Maybe he's got a self-care deficit. Also, you can see that big pocket of pus there just at the base of the great toe. And it looks like there's been some drainage and maybe a secondary wound there between the great toe and the second toe. Osteomyelitis is most frequently caused by Staph aureus, which we carry on our skin, but it can get into the bone, especially if they've done an internal fixation, or if it was an open fracture, or if there was some kind of surgical procedure, like if this person here, and I have no idea what happened to this person, but maybe he had a bunion surgery, or maybe she had hammer toe, and so they went in to fix it. It's very, very difficult to treat, and a lot of times it requires long-term IV antibiotics. People go home and have to get the IV antibiotics. Sometimes a home health nurse will come by and do that. Sometimes they can hook them up to a slow infusing syringe pump that they can carry around with them. But I want you to think about what kind of IV access do they have to have in order to get the long-term IV antibiotics. They have to have something that can be there at least 6 weeks, sometimes longer. So that's something to consider. So when you're looking at who do we send home with antibiotics, IV antibiotics, who do we send home with that? You have to consider their ability to care for themselves, or somebody there to care for them, or what's their living situation. You can't send somebody home with IV antibiotics if they're homeless or they live in a shelter, right? So that's something to consider. Manifestations of osteomyelitis, of course, include this pulsating bone pain. It's localized. It doesn't really radiate anywhere, and it doesn't travel anywhere. It's usually localized to the area of infection. Of course, there's the erythema and edema, all those classic signs of inflammation. Fever, because it is a bone infection. This is a pretty bad infection, so they're going to have a higher fever, but not a low-grade fever, but a high fever. They're going to have leukocytosis, which is an elevated white count, and they're going to have an elevated ESR, erythrocyte sedimentation rate, which is an indicator, a generalized, nonspecific indicator of inflammation. If somebody develops chronic osteomyelitis, some of these manifestations may go away. The bone pain probably won't go away, but some of the other signs that are manifestations of acute infections may wane and go away. All right, so ways that we diagnose it is bone scans, the gallium and the thallium. If there's inflammation, you're going to see those hot spots on those nuclear bone scans that we talked about. Also an MRI. MRI can show you problems within the bone and also soft tissue inflammation. And then cultures. Any of the drainage that you see, these infections in general will try to develop a tract or get some way to get the drainage out. So sometimes you'll see fistulas or little sinus tracts where they'll have some drainage of the purulent drainage. Treatment, IV and oral antibiotics, at least 3 months. Surgical debridement, they'll go in there and they'll open it up and they can go in there and scrape some of the bone out. Hyperbaric oxygen, surgically implanted beads. They also sometimes do intrathecal antibiotics, which means that they infuse it directly into the bone, and amputation. I actually know a couple of people who kept having problems with infections in the bone, who got an amputation because it wasn't healing. It was incredible burden on them, and there was no guarantee it was going to get better. So sometimes amputation is the answer, especially if the person has diabetes or some other kind of immune suppression that's going to prevent them from being able to fight the infection off. Nursing care is administer antibiotics and pain meds as ordered, perform those neurovascular checks, and dressing changes and wound care. You need to provide a lot of patient education, especially if they're going to go home on IV antibiotics at home, managing their long-term IV access, their PICC line or their central line, whatever it is that they get. There's a lot of nursing care that goes into this. I want you to consider that you know most of it already. This isn't new stuff. It's just that this is an infection in the bone where they have to go home with long-term antibiotics, and you've dealt with things like that before. All right, so we're going to talk about two therapeutic procedures. We're going to talk about arthroplasty, which are joint replacements, and then we'll talk a little bit about amputations. Okay, arthroplasty is a joint replacement, and the most frequently repaired joints include the hips and the knees. And we talked a little bit about this when we talked about obesity and the causes of joint damage. But with an arthroplasty, they remove the diseased joint and then they replace it. I will say that there's been a problem that the joints that are manufactured are not always made for different genders. And so a lot of women have had a hard time with joint replacement surgery because the joints are too big for their bones or too big for their frames, and they just continually have problems with it. When we talk about joint replacement, they remove the diseased joint and they replace it. It can be a partial or a total. Like when we talked about somebody having a hip fracture, if the pelvic side of the joint wasn't damaged in that hip fracture, they really only had to do was go in and replace the ball part of it, from the greater trochanter on up, and they can do that several different ways. It is a surgery it's a rough surgery. They go in there, first they saw off the joint, and then they saw off the thigh bone or the femur, and then they'll go in and they have this thing that grinds out the socket, and so that they can replace it with a new socket. And the way that they replace the top of the femur is they will hollow out, or they'll roto-rooter out the femur, and then they'll pound this replacement in there. They pound it like with a little sledgehammer to get it in there, and they use cement and stuff to make sure it stays in there. But it is a rough surgery. If you have Miss Eskew for clinical, you need to ask her about it, because she used to be like a first assist on some of those when she worked in the OR. All right, so pre-procedure, normal preoperative care. A lot of this is done preoperatively as an outpatient. They'll get patient education. They'll be assessed by PT. They'll get some education about what PT is going to be like. They'll get education about preventing post-operative complications. And they have things called joint camps, where they're in a group of people, and they stay with this group of people all the way from the pre-op stage throughout post-op and rehab. So they have this group of people they stay with and kind of support system. Okay, so they have labs drawn, an EKG, they get informed consent. Sometimes they know far enough ahead of time, they can donate their own blood for autologous blood donations. The other thing that they do sometimes with perioperatively is they'll use a cell saver, and they'll just reinfuse the blood they've lost. They have to have an informed consent, and they have to do the pre-op consent for blood as well. Post-operative, of course, you're looking at pain control. It can be done through analgesia, like with the PCA, patient-controlled pump, IV, oral, or IM. They also can do a continuous nerve block, depending on where the surgery was. Dressings, you need to know about dressing changes. Nursing never changes the dressing for the first dressing change. on any of these joint replacements. The doctors will come up the next day and change the dressing. They want to see the incision. They don't want anybody messing with it until they come up to do the dressing change on the first day. That's the first day post-surgical. You need to manage their drains. They have drains you have to remember, why do they have drains? They put drains in to take the fluid away because that will allow better blood flow and healing. So you need to wash the drains and know what kind of drainage you should be looking at. Initially, it's going to be a sanguineous to serosanguineous type drainage, but within 24 to 48 hours, it should just be serosanguineous to serous type drainage. That drain usually comes out within 24 to 48 hours. They may use the ice and cold therapy, just like I showed you with the scope. They can have that kind of ice or cold therapy. You need to monitor the patient for signs and symptoms of bleeding or hypovolemia. Sometimes you'll need to monitor them if they're a patient that has a history of heart failure. A lot of times they'll get loaded up with fluid down in the OR, and you need to monitor them to make sure they don't have any flash pulmonary edema. Now, this thing right here is called an on-cue pump. And within the circle, within the ball there, that is filled with an anesthetic and an analgesic. So it will be filled with something like lidocaine and maybe fentanyl. And you can see that it goes straight into the wound, and it's a continuous drip. And it's set by the pressure that's within that on-cue ball. And it provides great pain relief. I actually had one of these after a pelvic surgery, and I could have done sit-ups because I felt no pain from it. But it's a great thing to use. They don't use them for shoulder surgeries anymore because they've had a problem with adhesions. But apparently they're very good, especially for knee replacement surgeries. Post-operative care, you got to prevent these post-operative complications and monitor them closely. It is very important to monitor the patients who have had major surgery on bones, especially in their lower extremities, so their hips or their knees, to monitor them for DVTs. That is a high risk. Also, pulmonary complications, have them do the incentive spirometry to prevent atelectasis and pneumonia. Monitor them for UTIs. Get that Foley catheter out as soon as possible. We would rather them be incontinent than to develop a UTI. Monitor them for bleeding changes, not just there at the side of the drain or on the dressing. You have to monitor for bleeding within the joint itself and check underneath the patient for bleeding. And also monitor and prevent surgical site infections. That's one of those national patient safety goals is prevention of surgical site infections. And almost every hospital has a policy specific to surgical site infections, just like they have a policy to prevent DVTs and a policy for use of urinary catheters. So you need to look that up when you get to wherever you are going to go work. Knee replacement surgeries is usually after failure of conservative treatment. Conservative treatment includes medication, maybe an arthroscopy, PT, that kind of stuff. You can see the knee on the left there. Looks pretty damaged, the joint is rough, it looks inflamed, and then you can see the knee on the right. One of the things I want you to look at is in that knee on the right, you can see that post that goes into the top of the tibia, and that is driven in there using a hammer after the bone is hollowed out using a rotor tool, and it's cemented in there, cement glue. That's what a joint replacement looks like. Now this is a continuous passive motion machine, and this supposed to help prevent problems with immobility. You put the patient in this, a lot of patients call this a torture machine, and it straightens and bends the knee, and it's set for a certain degree of flexion and extension, and it increases over 24 to 72 hours. A lot of places don't use these anymore, and if a patient gets up and they start PT very soon, then they may not use this. But remember, one of the goals is things that we want to look at is early ambulation. The earlier they get up out of bed, the sooner they can go home. Hip replacement surgery, again, can be used for chronic arthritis or traumatic injury. And I want you to look at how this is done. The one on the left is just resurfacing of the ball and socket. On the right is a complete joint replacement. And this is what a complete joint replacement looks like. And this is a dislocated one. But I want you to see how far down that trocar goes in that femur where they've pounded that in there. And then if you look on the socket part of it, you can see like these little things sticking out. Those are actually little spikes sticking out, and they forcefully jam the socket up in there and glue it in there so that those spikes are stuck in there. Now, post-op care, one of the goals is to prevent dislocation. It can happen very easily. You need to look in your books at Boxing 4213. This talks a lot about ways to prevent that. But one of the most important ways is by using those wedges while they're laying in bed and while they're seated. And their manifestations for dislocation, increased pain and edema. They can't move their joint. They're having acute groin pain. A lot of times it's on the inside of the groin because they're pulling, the shortening and rotation of the leg, and a popping sensation. Other complications associated with hip replacement surgery include infection, bleeding, neurovascular impairment, DVTs, and delayed healing. You have to remember, a lot of these people who get hip replacements are elderly people and can have comorbidities that will increase their risk for infection and delayed healing. All right, so now we're going to talk about amputations and why people get amputations. They have peripheral vascular disease. They have an infection that won't go away. There's been a trauma. They have a cancer or congenital deformities. We see a lot of amputations in diabetics related to a combination of peripheral vascular disease and an infection. So they'll have some kind of damage to their foot and they get infected, and then it just travels up because they have the poor circulation and the problems with ineffective protection. Levels of amputations. They go in, the goal of the surgeon is to amputate as far down as possible where healing is most likely to occur. They can have foot amputations. If they want to use a prosthetic, they have to look at that. Where would they do the amputation that would best support use of a prosthetic? In the legs, a lot of times they'll do a transtibial, which is below the knee amputation, and that can very easily support a prosthetic, or an above the knee amputation. They can also do disarticulations where they cut it off at the joint. I took care of a patient one time who got hit by a coal truck, and she actually had a hip disarticulation and a shoulder disarticulation. And this was because of loss of the lower extremity was because of trauma, and the leg was so mangled. But for the upper extremity, it had a lot to do with the fact that that whole arm was denuded. All the skin had come off, and there was some damage to the underlying muscles. But they also didn't have any place to get the skin graft from to put on there. It was like having a really bad burn. They didn't think it would ever heal. And she was a smoker and had vascular issues, so they did a disarticulation both on the same side, both on the left side. But the way that they determine is circulation and also function, what they want to do with it. You have to look at the postoperative complications as well as skin breakdown, problems with bone infection, and also the phantom limb pain, and then joint contracture. And the ways that you prevent joint contracture is by range of motion exercises, and if they have like a below the knee or above the knee amputation, laying them prone at specific intervals throughout the day. That will help prevent contraction so that leg doesn't contract up back up to the body. They have different kinds of dressings and stuff. We used to have to learn how to do this figure 8 dressing for an amputation, but now they have sleeves and socks and stuff that they can use. They'll also put a rigid cast over it to help protect it, and it also molds the stump for use with a prosthetic, controls the edema, and it protects the wound. It can help prevent the contractures. So that's all you need to know about the amputations. Remember, when we talk about any kind of surgical procedure, you need to remember that you have to monitor neurovascular, you have to monitor for DVTs, pulmonary functions, pain, you have to monitor them for bleeding. Those are all normal post-operative considerations. Okay. Make sure that you review the use of assistive devices, crutches, canes, and walkers that you learned about in 320, dressing changes, and care and removal of drains. You may see that on the test for musculoskeletal. And that is the end of musculoskeletal system.